So now it's about Clinical Audit Awareness Week, and this, hopefully you've all seen the link and the information on our website. It's over June the 2nd to June the 6th, and it's 5 days. And during those 5 days, we have learn at lunch sessions, and we have a focus on each day. So one day will be about patient safety, another day about healthcare inequalities, another day about healthcare efficiencies, and one day I think it's about sustainability. But the reason we're here today is because our focus is, of course, on patient and public involvement. So what I wanted to discuss with you, all of my lovely Sun members, is we want to discuss these two themes: patient advocacy in healthcare and shared decision making. So if I stop sharing so that I can see you, because otherwise I can't see you. Maybe if I do it like this. Okay. Let's go with the first theme, and these are questions about advocacy. So I've put these questions, but I don't know if you want to, however you feel like doing this, if you want to answer the questions individually, or if you just want to take the mic and tell us some of your experiences. But the first question is, why do you want to be involved as a patient advocate in healthcare? So, Sarah.
From my own lived experience, in brief, there are so many things that I see and experience, and that my peers see and experience, and very often if you're an inpatient on a 24/7 basis, that could be better addressed. And I think when you're at the pointy end of healthcare, you're at the receiving end, you're gathering kind of live almost continuous information on what works, what doesn't work, what could be done better. And I think it's important to have PPI in healthcare, because it's a way of imparting vital knowledge into the system, which could help make it better for everyone, better and safer for everyone.
Thank you. That's a really good answer, and lots of hands now. So who is number 2?
I think for me, it's going through my health conditions and wanting to use my experience so other people didn't go through the same thing. One thing that I noticed is there was a lack of people from a South Asian background talking, so that's why I decided to get involved.
Thanks, Sadia. Meg.
For me, it was twofold. So I personally have got very specific viewpoints because I sit in various overlooked groups, or often overlooked groups, both as a woman receiving healthcare, as a neurodivergent person receiving healthcare, and also as a parent to children receiving healthcare for various different conditions as well. So I think I've got valuable insights on a personal level. But the reason why I think that patient advocacy and public involvement is really important is because clinicians and policymakers must consider more than just themselves. They need to have a wider worldview, and of course, we've only got our backgrounds, so being able to bring different backgrounds and experience that influence health need to be considered, and I think that this is the perfect way of doing that.
Brilliant, thank you, well said. Naomi.
I want to be involved as a patient advocate in healthcare because I've been a patient in mental health services myself, and I was not always treated with respect and care, and was rarely listened to during these experiences. I want to advocate for patients in services currently and do everything I can to ensure that their voices are heard.
You guys, you're saying these things perfectly. Have you all written them down? Because it's
I have.
said. Thank you. Okay, Amy.
Thank you. Yes, I think there's probably a lot that I can echo from others, but I think from my perspective, I think there are just so many aspects of care that are left wanting, and this is on various levels in so many different ways. And from my own experience, having a lot of different health conditions, what I try to seek to do is represent lots of voices from that, because I think that's probably one of the few advantages of having lots of things wrong with you, is that you can kind of represent a lot of people. And being sort of naturally empathetic, I'm always trying to consider other people's experiences. So if there is something that I can bring from all that actually improves services and actually really makes a tangible difference, then that's important. So I guess that's the main reason. It's just trying to make things better for as many people as possible, really.
Lovely, thank you so much. Okay, Robert, you're next.
Yeah, well, basically, I wanted to get involved in patient-public involvement because it's the public's right to. The public have a human right to talk about the care and treatment. And I wanted to try and break down some of the barriers and cultures to involvement that I'd encountered as a lived experience. Not only that, but for educational purposes as well, to feedback some of the positive care that I'd had whilst going through 2 types of cancer. I think that's very important, not to dwell on the negative, but to challenge some of the practices and to look for gaps in services as well. I think that's really important in order to involve and improve quality standards. That's what it's all about. It's about best practice. And I do think that takes a lot of courage. So all the participants here, I think, are very courageous, and they're to be applauded for that. So yeah, when I'm talking to nurses, what I look for is courageous nurses. And I think it takes courageous people to challenge some of the barriers that not just myself, but other people have found in terms of equitable involvement. Anyway, there we go, folks.
Thank you so much. Kirit, you're next.
Yeah, hi. So I got involved firstly with, I was a carer for both my parents, and they didn't speak English, so it was making sure that they were not miscommunicated, actually got to all their appointments, to make sure that they get the right services and not misinterpreted by interpreters. So that was how my earlier kind of carer role. And then more over the last 5-6 years, I was trailing through lots of patient public involvement kind of groups on different organizations and institutions. And I was appalled by, in the Midlands, certainly where I am in East Midlands, the patient public involvement Senate, when I looked at it, was non-diverse. So that I got involved on that basis to make it sure that, and then the other, now I advocate for other people as well who've got different lived experiences, again, helping them, and they kind of mentor me now as well, so they get the opportunity. I shouldn't be there everywhere. I want to give opportunities to others to ensure their lived experience voices can be heard.
Thank you, Kirit. Okay, Aurora?
Yes, thank you so much. So my motivation comes from both my personal and professional experience in the health and social care sector, and I want to make sure obviously that the system we navigate is inclusive, number one, equitable and grounded to the real people life. So
maybe there's a trouble. Sorry, I wanted to say that I got involved because of my experience in with the services, using the services. I had a positive and negative experience, so I wanted people, other people, not to go through what I went through for years with my mental health condition, and also yes, to improve the services. So I got involved in research first, and then I started. I noticed that I could, with patient voices, can make a change, and I got involved in education for a professional workforce, NHS workforce. So I could get involved in the education of the future professionals, and then I also work for the NHS. So I can I have another perspective as a staff member, and I can. All the things I witnessed as well in the NHS hospitals, so I can talk about them too.
Okay, thank you, Barry. All right, Aurora, I'm so sorry. You're like in perfect flow.
No, I'm wondering that if we are recording, it's a bit challenging. But
yes,
anyway, so linking with what Mary was mentioning, obviously I do have a professional experience in health and social care as well. So it's a combo of personal and professional experience to make sure, obviously, that the system we navigate is more inclusive, accessible, equitable, and grounded in the real people lives. So I believe that those with lived experience, whether it's a service user or a carer, because we have both in the space, can offer a unique insights. And the aim is to strengthen the services, shape the outcome of the health delivery, etc. Thank you.
Thank you, Aurora. Okay, that was brilliant. Really, really good responses. Thank you so much. So I think what we'll do is, rather than every single one of you ask each question, I'm going to come to you next, Hamid. So let's go to the next question, and then maybe we'll go to the people that didn't respond and see if we've got answers. So the next question is there a difference when volunteering locally versus national involvement? So Hamid, do you want to go?
I think there is. There's definitely, like I say, different horses for different courses. So some people like national volunteering if it's in person, like me, because I think I get to see a different city, I get to meet different people, I get to see a different perspective from a different area. So for me, I like that. That buzzes me. But I know of another person who doesn't like anything that involves trains, coaches, motorways, and prefers something that's in the local area because they like to feel like it's something to do with what is improving or is about something that's locally in their geographical and it's going to have an impact. So that's something we need to bear in mind. Also, there is a big, huge difference in volunteering. Sometimes there's more sense of identity and belonging when it's a local, few roads away from your house, and people that are there are also from the local area. You have a lot more in common. So there's that. So I think there's a space for both national and local. I think with national one is that you can bring people together from across the country online, even if it's not in person, whereas local, sometimes people become lazy and detached because even though they're local, they still think, oh, let's just meet online. And then that can create fragmentation. So that's something to bear in mind.
Point. That's an interesting point. I hadn't really thought about that because locally, I would have thought it'd be a lot more that you would do it in person because it is local, just by nature of it. But if there's still online, then yeah, it breaks down that community that you hope to have in a local involvement experience. Okay, Sarah.
One last point I'd like to
sorry. Yes,
one last quick point. I think also what's important is that when it's local, it's a roll-on effect. So I was invited to something that was to do with public health. I met somebody who wanted to connect interfaith organization with the public health agenda, and there was that link. And then there was somebody from another organization said trade union council, X, Y, Z. So everything local you can connect up and get involved with because there's still things that are in common or in the local area. Whereas nationally, sometimes it's hard to think outside that remit because everyone's got very different spaces and not really can connect about other things. Thank you.
Okay. Thanks, Hamid. Sarah.
I think there is scope to connect, to learn, to integrate, to connect, both locally, regionally, and nationally. And I think some of us also do PPI internationally as well. And I think it's great. I think all are so important. I think all thrive. I think all are opportunities to learn and share and make things better. And especially the wider the context, the more you have to learn. But I generally find there's a great commonality of personal and as well as service wide interest and drive, and a great sense of community amongst peers, especially when they're contributing. And I've done PPI in Pakistan and India, as well as Canada and the US, and these are very different countries. But service users are still very interested in each other and can learn so much. So I think there's wherever you go, there's that common spirit that people with lived experience have of wanting to make things better and to learn from each other how to do that better and to contribute better.
Brilliant. Thank you, Sarah. Sadia.
I think for me, when it comes to locally, I feel like the issues are not going to get resolved. And I say that because usually I think that the powers that be are further than my little tiny village, and that if I say something locally, the only way it's going to get dealt with is if it goes to the people who actually hold the power, and that usually is nationally. So I feel like when I'm doing involvement that's national, that one, I'm going to be heard better, but two, things will get done faster. Like people will listen to what I'm saying faster rather than having to go from local and go through all those hoops to try and find who can change it.
Okay, that's a good point. Thank you. Aurora.
I'm intrigued by both what Hamid and Sadia were saying. Obviously, it depends where you live, I guess, because for me, involvement at local health economy level often feel more immediate and personal. You can see the impact quickly. I live in Northeast London, so it's a very well-served area. And if we think about engagement, I can see the direct impact on the services and the community I'm part of. But I also understand that national involvement can be sometimes feel abstract. It can provide a sort of platform to scale up the issue. You can influence policy, you can influence standard, you can take part in research at scale. So both things are interesting in my opinion. I take part in both things. So I think they are valuable opportunity and they can complement each other. That's the key. Thanks.
So I think it's a really interesting point, actually. So like what you're saying, Sadia, with the whole nationally you can see things change while locally you can't. But I sort of agree with Aurora, because I would have also thought, because it's local, that maybe there's more opportunities to fix it because it's smaller and it's, within a smaller area, that maybe there's an opportunity to really impact change rather than nationally. But that's an interesting point. Okay, Meg.
Yeah, I was going to come and say very much the same as Aurora. Locally, I mean, they're both very valuable, but locally, I do find that it's more community focused and therefore it means more because it's directly impacting us. And while I do national work, it kind of works at arm's length, and quite frequently you see stuff being talked about at a national level that takes years, if it ever does, actually trickle down into your local region, and that can be quite frustrating. Whereas when you're working at a local level, things can move. I mean, I would say faster, but often when dealing with the NHS, so not fast, but faster sometimes than trying to change things nationally.
But then maybe nationally, I suppose that's where the big decisions get made, right? So that's part of it as well. Okay, Rob. Rob and then Amy. And then
yeah, just come off mute. Yeah, well, I think I've said it before. I live in a rural community where often it's hard to reach groups. So we have a very large Romani community, and I've come across where passive participants of society or passive participants health and social care, they don't know how to take part. They're not supported in taking part. And I do find that a lot of things are very urban centric, are very London centric. All roads lead to London paved with gold, because that's where a lot of the activity takes place, doesn't it? I mean, that's where we have the Houses of Parliament, that's where we have all the ministries. So for me, I think somebody else said, having been down this journey, it's for me, it was how Kirit said, actually, I agree with him. It's about how we support others from becoming passive participants to actually empowered participants of our own communities, and how we then support them. And personal development really is important, how we develop them to become participants and leaders within health and social care. I think that's the important thing. So education, as I said before, is vitally important. So have we not considered doing what I would call an empowerment course for communities, so that we can teach them in how to participate in meetings, what not to say, what to say, because it's like going into a maze. It is really, and you can come unstuck. I'm saying that because I'm an ex-glue salesman. That's a sticky business. We don't want people to become, there's a joke there, folks. We don't want people to become unstuck.
Got that, the glue.
Thank you. We don't want people to burn out, do we? But at the same time, we don't want to see the same faces. The ones that are powerful, the ones that get the prime opportunities. And I've found that locally, and I've said it to you outside the meeting, Kim, so a lot of people are cherry-picked because if they sing from the corporate hymn sheet, they will get elevated. It's not about making celebrities. It's about listening to every single member of our community about what their experiences are, good, bad, and what have you. It's not about politics. It's about our health and social care, folks.
Yeah.
It's about our carers. Anyway, I'll shut up. I could be on I could end up preaching and I don't want to.
So something that's important, because absolutely your message is really clear and that's the right message. But just, I know it's just language and sometimes it's just semantics, but some of the terminology, like saying hard to reach, is actually like this. It's something that I really move away from, and I try and make sure that the projects we commission also don't say that, because it's not about people being hard to reach. It's about us, you know, the NHS not reaching them. It's, you know, we're making it hard for them to reach us, right? So I think you're absolutely right about giving people the opportunity, and empowerment courses love it, with them having the opportunity to engage with us. We've got to make it easier for them to engage with us. Okay, let's go to, so I think next is Amy.
Thank you. Yeah, I think another perspective from the actual question, I was thinking that in terms of the actual involvement and how it happens, I think there maybe isn't a huge difference between whether it's local or national. A lot of it is online. But I think one thing that's, in terms of your welcome and whether you're heard or not, or things like that, it seems to be fairly equal, whether it's local or national. And I think a lot of local things do tend to connect in some way nationally anyway, or they have the potential to influence things. So there isn't necessarily that huge divide, because I think a lot of things do link, or you might be involved in, say, something that's with a local charity but actually does have a national presence as well, but maybe they function slightly differently, but there still is that chance to make that difference at a greater level. One thing I have found with more national involvement though, that it does seem like anything that is national is better at inclusivity, and you do have that breadth of different people from different backgrounds, perhaps a lot more so than maybe local things, but maybe that's just my experience. So that's one key difference, I suppose. But other than that, I think there is a lot of things that you can actually see change. It may be a little slower nationally, but I think in either way, you can actually see the differences that you're making, even if it takes time. So that's a positive.
So it's interesting what you're saying about there's more diversity nationally, which I suppose overall, of course, makes sense. But I think the difference is, and I find is a challenge from my perspective doing national involvement, is that I'm not right there seeing the communities work, you know, because we're talking now, I don't know, whether it's asthma, and we're talking about the whole of UK, you're not able to go to communities. I don't have access to local engagement to go to that specific community that's over there and that community over there and go in and engage. It's harder, I think, to find that nationally. Does that make sense? Because you're not on the ground. If I was in a hospital and I was doing engagement, then you know the areas around you and where you can go to those different communities and seek people's views and ask them to contribute. Cool. Carol.
I think the difference is, I mean, I do national work when it's something like the nutrition and hydration project, which is about changing the way that the NHS, all the hospitals, deal with it. So that's a sort of people are picked from different realms, different areas, and then there's inevitably the token patient partner. But I've said anything that I join, I want there to be two of us. So I think the difference is that if you just go national with something, as you say, like asthma, then that's a different kettle of fish. But if you go national and you're on a national project, then that's something that is, you know, it's peculiar to the project that you're working on. So I think there is a difference between the two. I think it's a lot more not effort, but it's a lot. There's a lot more involved in working on a national project. You've got to really know what you're talking about, and, well, more to the point, know what everybody else is talking about. I mean, I actually quite enjoy it, but I think that locally, the big advantage of local is, you know, in the word, the local bit. You can get out there and see people. You can get involved with people. I mean, when we're talking about equality and diversity, we had, when I was in Reading, we had a big influx of people from Nepal, and everybody said, oh, it's quite difficult to engage with them. But I went down to one of the big fetes that was on and offered to and volunteered as a rubbish collector. So I went around with a black bag and a grab handle, which meant that I could go and talk to anybody on any of the stands as an equal, rather than going as a, you know, a patient partner who was, you know, yeah. So I mean, I just chatted to them, and you can do it. And as for hard to reach groups, they're not hard to reach, they're just easy to ignore.
Yeah, that's it. Thank you, Carol. Okay, Naomi, and then we'll move on to the next question.
I'll be quite quick because I've only really volunteered on, I haven't really done like national volunteering. It has like always been local. So yeah, I haven't really got that experience. I would like to, but I think I struggle with traveling. I don't drive, so I'm quite limited to where I can volunteer. So I've only ever really volunteered in my like local area.
Okay, but what you're doing now is national involvement.
Yeah. So I suppose in some areas I've been involved in like national things, but most of my stuff is like local level involvement, I'd say.
And do you find that you can reach communities more easily? Well, you don't know comparatively, but do you go into communities with your involvement locally?
Yeah, I think you can get, I think I agree with what everyone else has said, really. I think there's different parts with both. I think there's benefits and like pros and cons to both sides of it. I think I would like to do more national volunteering, I think, because I think you can get more into like you say, you can get into the people at the top more if you see, like when you do it that way. I think when you're doing it like locally, it's kind of drip fed to you from the top, if that makes sense. So yeah, I'd like to do both.
Thanks, Naomi. Okay, so then the next few questions, I want to try, maybe let's do them all together so that we can get through it all. So I've put it in the chat box. Do you participate when there is no payment? Maybe that's a quick yes or no. Carol, is your hand up from the last time?
Yeah,
let me lower it for you. Okay, Aurora, have you got a quick answer to that question? Do you participate when there's no payment for involvement?
So I do contribute to some unpaid work, especially if it's aligning with my value and it's clearly benefiting my community. But I also advocate for fair recognition of time and expertise. I did write an article, it's on my LinkedIn, in collaboration with UM Council, where I was outlining the alternative to monetary, payment. There are so many other things that the organization can do in order to support the lived experience partner. Thanks.
Thank you, Sadia.
Generally, I don't if there's no pay, unless I'm gaining something else in exchange. For example, I might volunteer as a chair because I want chairing experience.
There you go. Great answer. Naomi? Mute.
Sorry. Normally I do get paid for the work that I do, but I'm also happy to do it unpaid as well. I've done both.
Thank you. Who's next? Sarah. Sarah?
Yes, I do. I do, especially if it's PPI in a funding application for research, and very often there is no funding for the PPI then. But I really believe in the research that they propose to do. And in some cases, I've been involved unpaid in this capacity for years and years and years until we finally get some funding. So
Yeah.
if it's something I believe in it, I'll stick with it.
Thank you, Sarah. Kirit.
I think I was going to say is, generally, depending on what the area of expertise, and if I have that, I have shared on a voluntary basis. But the other thing I'm a bit cautious about is that people using that as a tick box and not valuing that. So it's now, I have to say to them, well, depending on the time commitment, you need to compensate because I'm bringing X, Y, Z expertise. So, but yeah, generally, if I do both when necessary.
But I think I hear your point. It's about, okay, you all have volunteered and would volunteer if there's something you really cared about or if there was some experience you were getting, but it's about being valued, isn't it? So sometimes, and as Aurora mentioned, it doesn't have to be a payment. There are other ways as well. Amy.
From my perspective, there's quite a lot I do unpaid, to be fair. But I do kind of agree with a lot of other people say, because I think if you do too many things, then you do tend to get taken advantage of, because if you're too willing and you're not perhaps even valuing your own insight or expertise, then other people tend to then ask for more and more and more, and then you kind of potentially, not in all cases, but you could lose some respect to some people, it seems, which is not great. Because you end up not being treated very well. And I've had that a lot in certain charity work that I've done, been treated really quite badly, and I'm just sort of like a workhorse for them, and that's not fair. So I think there's a balance to be struck, really. I think it's important that people do get recognised for the value they bring.
Absolutely. Thanks, Amy. Meg.
I'm quite a hard no. I'm an expert by experience, just like the rest of the people at the table are experts in their various fields, and my time, effort and input is worth no less than theirs. And I think on a broader scale that actually when it starts to be built in as a cost, it actually raises the value of PPIE more generally across all sorts of different boards and organisations. So think of it as like a charitable endeavour.
I think you're absolutely right. It's a really good point, because we commission the National Clinical Audit, as many of you know, and as part of our commissioning, it's an expectation for all of our commission programs to do patient public involvement. And more we are seeing as they apply, it's part of the costing. They're costing it in, whether it's subcontracting, putting it into their cost tables. So they're actually right up front, they know they've got this budget and that they can pay for people's time. Rob.
Well, this is a very emotive subject, and I'd like to turn the question round to the health professionals and the powers that be at the very top table. Do they really value people with lived experience? People that have become empowered, that really want to take part? They may have trod the boards for quite some time, so it's about equity. Meg mentioned that. I totally agree with what she said. If we value our input, it's about personal professional development. How do we develop people so that they can take part equitably? Yeah, it's a touchy subject myself at the moment, because I run an independent service user care company, and I've seen our business cut from academic institutions at a time when they pat us on the back and tell us how wonderful we are for the work we've done. And then the next minute, we put in the guards van, not in the engine, and that saddens me greatly. It really does. I don't want to be soft. I don't want to be soft soap.
Metaphors. You've got quite
I don't want to be soft soap by deans of universities saying how wonderful you are, when we've clearly identified the value that we offer. When students come to us and say, "Wow, I couldn't learn that from a textbook. That was powerful. That was powerful." Yeah. Mm. Let's do away with the sackcloth and ashes and the chains of service user care involvement. Let's cut them. We are professionals.
Thank you. Thanks, Rob. Okay, so then we've got the last two questions. What are you most asked about as patient advocates. So when you're asked to be involved, what are the things that people are asking you about? Are they asking you about your lived experience, to be involved in producing resources, looking at information and giving it that patient view, patient perspective? Is it about your experience through a treatment pathway? And then the last question is, what else would you like to say? So if we could sort of try and answer the questions together, and then we can have a break before we go on to the next one. So the first hand up is, I think, Rob, you had your hand up from before, so we'll give someone else a turn. Hamid?
Bringing me in, I think that one of the things that we get asked is, as PPIs, patient advocates, however you want to term us, new term is now, I'm very impressed, I've got a new term which I want to share with you all. I'm no longer a PPI, and I'm no longer a service user or a carer. I am now a lived experience partner.
That's right.
Oh, no.
Come out. And I love it. Because I love that, because it's so, I think I can see Carol doesn't like the term, and I appreciate that. I understand that whatever term we will come up with, there will always be somebody that's not happy, which is fine. I think we all got our own views on it. But the reason why I liked it, because I used to go to meetings and it'll be like, so-and-so's the director of research, so-and-so's the project manager, so-and-so's the clinical lead, and it comes to me and it's like, you're a patient or you're a service user. And you felt like things were done to you rather than with you. So I like the idea that when I go, I'm just as equally partner on the table, and I'm just as equally valued as the clinical director and the top research investigator on the table. So that's why it sits comfortable with me, because I don't have to go in and seen as a victim or seen as a user of services. And also it's where now we're saying your lived experience matters, it's important, it has a stake in the development. So I'm not expecting anybody to claim my lived experience title, and I'm happy with what you are happy with, but for me, it sits very comfortable. So I like the fact that we are now getting a bit more kudos in spaces that recognize that we can say things as they are. That's the right word. Sometimes I've noticed that researchers are so caught up in how researchy world is, that it's very hard for them to connect with the reality. And same with clinicians, they're so used to giving services that they can't really understand what it's like to be on the other side as a patient. So when I go in, I can say things as it is. And I always say that the beautiful thing about being a patient advocate, this is my last point, is that we don't have to be politically correct. I'm very mindful. I'm never there to politically offend anyone, but I don't have to hide behind the PCs and try to be politically correct. We just say as it is. And because we say things as they are, improvements happen. Did you know that out of hours GP services happen because of the patients? Because we were saying it's not working out, it's rubbish. I've got work till 6 o'clock. By the time I get to GP practice, you close, and then we start getting GP services till 10 p.m. in the evening. So that's what I want to finish off, is that I love the fact that I can say what I want, how I say it, because I'm not bound by organizational protocols and code of conduct and all that, but I'm very mindful of being, not being a professional, but conducting myself in a professionalism. Thank you.
Thank you, Hamid. All very nicely said. Sarah?
For me, I think the emphasis, as it should be, is on the lived experience, having the right kind of lived experience. And I think, looking for that authenticity. So not just being a generic jobbing PPI person, but having the right type of lived experience for the meeting at hand, having the right type of lived experience for whatever project is at hand. Because generic PPI, is less value than actually deeply informed, deeply lived public and patient involvement. And I'm glad that increasingly both researchers and service providers are recognizing that the people they need in the room are the people with the lived experience to the project at hand.
Okay, yeah, that's a good point. But obviously there's still work where we need that patient perspective, that layman, that public point of view that's not about a specific condition with specific lived experience. I mean, it definitely happens within HQIP and the work that we do with some. Okay, Naomi. Mute.
Sorry. For me, I found in my experience working as a patient advocate that I've been asked mainly about my experiences on wards as an inpatient and how I found it. I've been asked to look at policies and create resources and talk to professionals about my lived experiences, such as I did a talk to GPs and things like that. And to the question, what else would you like to say? I just want to say I feel really privileged to be able to be involved in so many different projects, and it has given me the opportunity to use my lived experiences to help improve services for other patients. I like that we can make things more than just tick box exercises, and that we can show how much we genuinely value the insights of those who rely on the services daily.
Brilliant. Really well said. Thank you, Naomi. Okay, Carol.
I don't like the term lived experience partners all very well until you just get to the initials, and they're called LEPs, and I really don't like that. So I've been a patient partner right from day one, and I mean, there was a time when patient leaders was the terminology that was used, and you know, Health Service Journal did this thing about the top 50 patient leaders and all the rest of it, and that created quite a lot of conversation, because we're not, you know, are we leaders? Who do we lead? Does it mean that everybody else has got to follow us and all that? As somebody's put up on the chat thing, what's in a name? You can argue until the cows come home about what we should be called, and I'm just quite happy being called a patient partner and advocate, and I will do my bit to be both. So that's me.
Thank you, Carol. And Sadia.
I think one thing that I get asked quite often, other than like what my experiences are, being asked about my professional qualifications, and that kind of upsets me because I'm there as someone with lived experience, and you can't always professionalize your lived experience. So I cannot give you the fact that I have a qualification in my health condition, but I've lived it, so I may as well have that qualification. But it's just something that I've noticed, especially recently, and when you go for positions that aren't kind of the one-off focus groups, it's those people who are asking you about those professional qualities. And I always find it really hard to answer because I didn't get my experiences through a profession. I got it through living. So then how am I supposed to tell you how that translates to professional qualities? And I think as well, especially with young people, they find it really nerve-wracking to advocate for themselves in terms of payment or rumination. So what I really like is when organizations or companies or, you know, anything of that sort, they have like an involvement payment document already, so that young people aren't asking about it, because they'll be very unlikely to ask about it or undersell themselves and not get what they're worth. And in terms of question 5, what else would I like to say about public patient involvement opportunities? I would say one thing is I would love for them to be talked about more often. And the way that I mean that is, recently I was at a conference, and I was with a group of young people, and they were all med students, and I was telling them about PPIE, and they had no idea what I was on about. And I was like, but you're med students. And so I explained to them that usually universities have like a web page, but they had no idea about it. So I think we need to sing and dance about PPI a little bit more, so people are aware that you have this option. Your voice can be used for good.
Brilliant. Thank you, Sadia. Amy.
Thank you. Yeah, I think from my perspective, it is quite a balance in terms of what one is asked. It can be very specific things, or it could be, you know, you're being part of a working group that might be working towards a particular resource, and then you're all contributing, or you might be writing something, you might be sharing a story, but from a certain perspective. You know, there's a whole host of things. But I think one of the things is, and it's interesting hearing other people's viewpoints. Yes, some people might be asked because of a specific experience, but actually, I think more and more so, there is that just the fact that you are somebody with lived experience, you are welcome. So even if you may not have a specific experience in and of itself, your voice can still be valuable, because I guess you're bringing that greater level. Oh.
Sorry.
It's okay. You're bringing that greater level of, I guess, diversity in a different background. So actually you still have that relevance, even if you don't have direct experience of a specific thing that might be being discussed, or there might be a link to it. But I think an interesting thing that Sadia had said, I think, is the fact that there is almost that sense, and I guess it comes back to this labelling thing, is that maybe there's still obviously that a lot of work to be done, because it's almost like if you have lived experience, which is tangible and should really matter, and you know, that is the evidence, you've got that evidence, but actually a lot of people in these sort of professional capacities are seeking for you to show, you know, to qualify that evidence, to say, well, what have you got to back that up? What data have you got? You know, anything like that might, you know, you can't provide that as a lived experience person. But also the fact, I guess, that you're kind of, everybody's not quite sure what they should be called, I guess calls into the question, you know, whether things are, I think it's getting better, but I guess it's that kind of validity. We really want to bring the value to what we're doing, and the confusion over what we should or shouldn't be called, I guess, kind of takes away from that as well. So that's another point.
Okay, thank you. Okay, we'll just quickly these last 3 points and go for a break. Kirit.
Yeah, sometimes I actually question, am I there as a token being asked for my tokenism, or but then sometimes I actually say, well, I have to be there because there's a lack of diversity in that group. So that's what I'm asked about. And also I come from an equality background, so I think sometimes that's also helps as well in terms of what they want. But going back to the question around qualification, I always say I have a PhD, not a PhD in as the normal PhD. I have a PhD which is called personal health development, and that's what, you know, helps to then bring your lived experience voice as well.
Brilliant. Thank you, Kirit.
I really like that. That is beautifully said. I like that. I think we should use that more.
Oh, he's back.
I think we should use that more often.
Yeah, that's a good one. Okay, Rob?
Yeah, I think Sadia was very eloquent in what she said. It's brilliant. It's about marketing, isn't it? It's about how we market patient and public involvement, not just to the higher educational authorities, but across the wider spectrum. You know, we're not an afterthought. We're not an optional extra on a car, are we? We should be a fixture. So to me, coming from a marketing background, it's about how we market the services, skills and abilities of genuine participants of involvement. I think for me, that's what it's all about.
Thank you. Aurora, you're back.
I'm back, sorry, medication delivery at the door. So I'm often asked about how to make involvement more accessible and meaningful, and not just a tick box exercise. And people are really curious about how to truly co-produce services. So when they reach out to me, they ask how they can improve communication, how to learn from lived experience without tokenism, etc. And I also get asked about how the system could do better support for carer, because I have carer responsibility towards both mine-in-law. And I also work on policy and treatment pathway that can reflect the real world complexity. So this is what my involvement looks like. Thanks.